I'm going to do something slightly different from what I usually do when I do a presentation that's linear, that you can see from your perspective. This time I'm going to ask you to put yourselves in my world. I'm going to invite you in and try to, so that you can see what it's like to have ADHD. I'm going to give, since this is the service user perspective, I'm going to also give a couple of aspects on the NHS reforms, because from our perspective, this is the elephant in the parlour that can't be ignored. I should add the proviso that all the views I'm going to express today are my own. I'm going to take responsibility for them. And then one last thing, since I have ADHD coupled with dyscalculia, I don't have any time perception at all. So I'd really appreciate it if someone could give me a 5-minute warning so that I know when to stop the time. Thank you. Right, now to move forward, and I've got to see if I remember my instructions. Nope. Right. Since I like shortcuts, I don't like too many steps. This is the same as it's always been, so I just reuse the same slide. Nothing new here. Right. Now I'm going to do this in 2 sections. And I'm sorry about using notes, but since I have a lot of thoughts buzzing around in my head and only one mouth to express them, I need my notes to keep me organised and to move on. I'm going to do section 1 in 4 themes. These were the 4 themes that I couldn't disentangle when I was trying to prepare this talk. So I decided to go with them, and I'm going to ask you to view them from my perspective of having chronic problems with concentration, distractibility, irritability, impulsiveness, restlessness, and disorganization. There's going to be a fairly short section. The next section, section 2, I'm going to pull it all together from our perspective, and that will take a bit longer. I also want to emphasize that I'm not advocating that we have a lifelong attachment to a service, because we do want to move on and live our own lives. But since ADHD is a lifespan disorder, some of us will need to periodically come back into the service to get help with certain things, like changes in our lives, sort of like a refresher course. Now we're going to move on to service user involvement. Oh, sorry, forgot my instructions. Right. This one, first of all, involvement implies active participation. We want our voices to be heard. We're not passive recipients of services, and we're not pawns to be made use of and not to be sacrificed when budgets get tight or when the NHS has to make savings. And I did read yesterday that there's a new IPPR report out that says that the NHS will have to make cuts of almost 8 billion, and I didn't have time to check on that figure, after the next election, provided that George Osborne continues with his austerity measures. I should also make clear that I'm not talking about service user involvement just at the trust level, but also at practice level. We'd like to see more engagement at the practice level between clinicians and us. And we are willing to help with that. Also, as has been said, we can be very helpful in helping trusts and clinical commissioning groups to see the wisdom in funding ADHD services, because we can say and do things that you can't. Right. Oops, still don't remember. Right, service user involvement. These are reasons why it's important. It's pretty self-evident. There is a legal duty. This Health and Social Care Act, 2012, whatever we might think of it, does actually have several clauses about the duty to promote involvement of patients, even at the clinical commissioning group level. Section 14U says that CCG must, in the exercise of its functions, promote the involvement of patients and their carers and representatives in decisions which relate to the prevention and diagnosis or their care or treatment. That's worth knowing. Also, the CQC, even though they don't seem to have very many teeth, does list as outcome number 1 that people should be treated with respect and involved in discussions about their care and treatment. Involvement is going to be even more important in the new NHS because a few CCGs, including one down the road from here, have expressed a wish to add ADHD services to their any qualified provider list. And if they get this, then the services will be outsourced to private providers. Now, I've lived in America for a long time, and I know that private companies and health insurance companies don't like ADHD. Their actuaries think that we're expensive and quite high risk because of comorbidities and accidents. I actually had to struggle in America to get them to cover my ADHD treatment. And I was only able to get coverage for medicines. They only paid 80% of $120 a month, which meant I was significantly paying a good chunk of money. Also, I think that feedback you capture from us can help highlight areas for research. We would like to see a little more research into the subtypes of ADHD, which actually Professor Ashton has covered, and into the role of comorbidities, particularly how they can make things worse. For example, I have dyscalculia and ADHD, and I had extensive testing done, 12 hours altogether, not all at once, which showed that while I was in the 99th percentile for reading, comprehension, written language, knowledge and spelling, I was in the 3rd percentile for math skills and math reasoning. Those skills don't just involve maths, they affect daily living. The report said that while I have the knowledge and ability to formulate complex ideas and responses, I have significant difficulties in areas of short-term memory, big surprise, visual processing speed, and visual processing abilities. And they said that this makes it hard for me to express my true abilities. Well, they weren't wrong. They're not wrong. And I can't tell you, even though I am verbose, I am not able to describe how painful it feels to have such a huge gap between my abilities and my actual level of performance. There's a lot of pain there. And there's a lot of other adults out there like me who also experience that pain. Partly it's because while I have abilities, I actually have trouble hanging on to a job. And our self-esteem comes from having work. So we need research into those kinds of things, and this is things that we would like you to capture in your daily interactions with us to help that research. Right, we're going to move on. Right. Looking at the websites of trusts to learn more about service user involvement, I see this interesting term used, ladder of participation, that the NHS likes to use. It actually comes from an article written by Sherry R. Arnstein in 1969. But in her original article, she's actually talking about a difference between going through the empty ritual of participation versus having real power needed to affect the outcome of the process. You'll see later on that I have my doubts about the NHS service user involvement. And Arnstein says that participation should really be about the redistribution of power that enables the have-nots that are presently excluded to be deliberately included in the future. Right. I've taken part in a couple of exercises with the NHS on joint strategic needs assessments and designing or what they call recommissioning services, and I've got to say that they felt like hollow exercises. But I'm an optimist, did it anyway, and got free sandwiches. Right, this is the ladder of participation. On the left-hand side, you have the one, you have the one that Arnstein devised originally. And on the right-hand side, you have the one that the NHS uses. Arnstein's model says that levels 1 and 2 are non-participation. 3, 4, and 5 are tokenism. So you'll see that the first 2 rungs on the NHS ladder are tokenism. If that's all you get, that's tokenism. 3 and 4 are getting into partnership. And then 5 is delegated power. And you notice on the NHS one, citizen control is missing. Now, there's a difference between delegating power and supporting local initiatives. Delegating means to transfer authority and responsibility. It's quite strong. Supporting local initiatives means to assist them, encourage, or improve. It can be seen as being patronizing. And that's how I took it. And I don't want to waste my time anymore on that kind of exercise. Because if I've got ADHD, so if I don't want to do something, it's not going to happen. Or if it does, it's going to be a difficult process for everyone. And this kind of thing, and the reason why I'm using this is because this kind of thing can go on in the doctor's office too. And I'll talk about that later. Now we're going to move on to the next section. Positive outcomes, self-explanatory at the moment. These were some positive outcomes of ADHD services that I listed, that I came up with. It's going to be important with, I think, payment by results. Now, I'm not going to get too much into that because they were really quite annoying. Also not going to get into how ADHD will fit into the cluster of needs that they've devised, and fitting in is always a problem with us. The Department of Health says that payment by results is a transparent, rules-based payment system in England, blah, blah, blah. And I've got to say, it didn't look transparent to me. And I wasn't at all sure how it affected patient choice, and I even wondered if it was just smoke and mirrors. Anyway, apparently towards the end of this year, they're going to agree upon which quality and outcome measures will be used to get this PBR. I leave it up to you to figure out how that's going to be done. We're going to have something called a patient-recorded or patient-reported outcomes measure, a PROM, and you're going to have a clinical-led outcome measure, a CLOM. I prefer the PROM, sounds more musical. But anyway, it sounds like we're going to have an active role in assessing the quality of services we receive. Right, moving on to the next one. Different levels of service users. Didn't really like the way I used the word levels, but what I mean by this is that some of us have more experience than others. Some adults with ADHD may already have high levels of contact with services, either satisfactory or unsatisfactory, and that's going to affect how we are when we come into your offices. We are at different stages of accepting, understanding, and experiencing our diagnosis and treatment. So we want different levels of engagement. We also have different comorbidities, as you've heard, and that will affect how we interact with you. It also means that some groups may be excluded from involvement activities. I sort of came up with this. It's a bit simplistic, but I was finding it a bit, I told you, you've got to come into my world. It was a bit tedious working on this. And if I don't like doing something, it's very difficult. So the beginner is someone who's not been diagnosed or is only recently, may not have had high levels. Their needs are different. Then you've got the intermediate, being diagnosed for a while. It's all pretty self-explanatory. The experienced user, which I consider myself to be, been getting treatment for some time, and the level of contact with the service will have fallen off considerably. We may even have been discharged. There is some crossover though. I met someone who was diagnosed a long time ago, but never got treatment. And so although he had been doing a lot of work himself on understanding his condition, he had not had any treatment, he had not had any contact with anybody else with ADHD, and was basically floundering. So he was a crossover between the beginner and intermediate. Right. Putting it all together. I got carried away with the gardening motif here. I do want to say that, on the whole, service users are pretty happy with ADHD services. And the criticisms I make are not aimed at anybody here, because you're here, you're the good guys. These are thoughts to take back with you and to pass on. Also want to remind you that while service users are pretty happy with ADHD services, sometimes it's because we're comparing them to a time when there were none. There are some services that only provide medication. Medication on its own is not always enough. And there are some trusts or clinical commissioning groups that are only commissioning assessments without follow-up treatment. And I have to say that that's cruel. So now we're going to get into pulling it all together, incorporating this sort of involvement into everyday practice. Really and truly, it's quite simple. Really, all I'm asking you to do is to engage with us. We like participation. We like to interact, most of us. Here in Bristol, in a hiatus between consultants, we a learning disabilities doctor filled in. And he was very deadpan, very unemotional, and gave no reaction at all to anything I said. And even though I know better, I found myself deliberately clicking my pen just to provoke a reaction out of him, just to see if he got annoyed. And at the next support group meeting, other service users also reported having the same reaction. See if they could stir him up. We weren't successful, but he was looking a bit tired by the end of his tenure. I also want to say, too, capture any feedback, but don't ask permission first, because we might hesitate and say no. Wait till we start giving you feedback and then say, do you mind if I note that down? And by feedback about things, I mean things like how we got there, because it can affect the way we appear. For example, since I have ADHD and dyscalculia, I actually have trouble driving. I mean, I've been lost going to Bristol. Complete nightmare that was. Rush hour on a Friday afternoon. So I have arrived at the doctor's office completely frazzled by the effort it took me to get there. Others report that they actually have to take about 3 buses to get there. Also, a lot of people will say that they don't like to take the medication, although it works, because it has a dampening effect upon them. Some say that it feels they're not as creative. I want to say that I don't think it makes me less creative, and in fact I am able to finish what I've started. But off medication, and I do take medication holidays, off medication I have moments of a sort of quiet joy. I would not describe it as euphoria, but I have lovely moments. They're not there when I take the medication, and I miss them. The medication does help, though, with overcoming a corrosively low self-esteem. Right, so now we're going to move on. I'll get the hang of this. Right, first rung on the ladder. And over here you have positive outcomes with the different levels of service users. We're all about the same here. Information, the NHS says that the first rung is letting people know what you're doing. Well, too frequently from our perspective, this is actually a one-way flow of information. We get told a bunch of stuff, go home and find we've forgotten it all. So at this level, it's important to check with us to make sure that we're following what's said, that we're remembering it, and it would be really helpful to give us written information, decision aids, or something along those lines. And that's why it would be important to capture our feedback and capture frequently asked questions. Also understand that at this level too, lay and professional misunderstandings, miscommunications, and misconceptions can lead to service user disengagement. For example, people may have looked up what an ADHD assessment is like. They frequently come onto our forum and ask questions, and people say what it was like for them. So then if they go through the process and find out that it's slightly different from what they were expecting, it could cause them to doubt what was going on. And some may even question whether the doctor really knows what they're up to. On to the next one, consultation. The NHS says that this is where they're asking for views and perceptions, and then they will take them into account. So you notice there's no real commitment at that level, because we're still at Arnstein's tokenism level. But at the practice level, it is usually different. And this is at the level, I think, where treatment options might be discussed. But for this to work, and actually, I'm sorry, I forgot to mention, you can see that the experienced user here actually wants something that will help them with living a normal life. The beginner there has hope that there's going to be a normal life. So to go back to what I was saying, at the practice level, with the clinician and the adult with ADHD, treatment options might be discussed. But for this part of the process to really work, clinicians need to remember that treatment is preference sensitive. And if you don't ascertain the preference, the user will end up not trusting you. So not all adults with ADHD, for example, even though they may need the medication, not all of them will want to take it. They may be afraid they're going to lose an edge. They may have read newspaper reports, the Daily Mail or Peter Hitchens or someone like that. Or they may just simply want to try another method like CBT. Then this is where problems can occur. If you're in an area where CBT is not funded, there may be an inclination to offer medication instead because you want to help that person. But you need to bear in mind that they may prefer ADHD. It has to be handled, CBT. It has to be handled carefully. On the other hand, users may actually want medication, but they haven't realized that their PCT only commissioned an assessment and not follow-up treatment. That also needs to be handled tactfully. Can't just tell them to go back to the GP and ask for another referral. You're telling that to someone who's already having trouble coping and has already made an enormous effort to get into your office. Right. So now we move on to the next run, deciding together. Then you can see that the positive outcomes have changed slightly for the different levels of service users. But the top one is empowerment in all of them. We want to move on out into our lives. There are things we want to do and realize. The NHS says that this is deciding together, collecting a range of views and then choosing an option together. And we're moving now out of tokenism into power. But again here, what I mean is there needs to be a partnership of equals with the clinicians, you guys, providing medical expertise. We are providing knowledge about ourselves and our own lived experience with ADHD. This is not us being guided into treatments that the clinician deems appropriate. There must be a proper exchange of information and proper listening. And that actually could involve pulling some of the information out of us. We may find it hard to express our thoughts when they're all buzzing around in our heads like bees feeding on clover. It's really hard for us to pull the thoughts out in an orderly manner and out this one mouth to you. Also, the other thing that can affect us at this point is mood instability, which Professor Asherson talked about. I know that I experienced that. At one appointment recently, I was trying to express my frustration that the meds are not good enough because they don't help me overcome some of the weaknesses. They don't touch some of them. And I was feeling, I couldn't express it well enough, this frustration, this pain I feel. The pain that I said is between the gap between my abilities and my level of performance. It's so much, it's hard to express. So I was starting to get upset. But then somehow the talk shifted to how the medications do help. And I remembered that I did get my bachelor's and I got the master's. And I was instantly all happy and bubbly. And I bounced out of that office and it seemed everything was hunky-dory. Because I had temporarily forgotten the other side of me, which is this deep, painful frustration. And it might seem odd that we can forget those things, but this is what happens in the ADHD world. Oh, thank you. Better hurry along. Right. Acting together, let's whiz through this. This is, according to NHS, forming a partnership to decide and take action together. This may include a referral to another service provider. We have complex needs, and we may need help with drug misuse problems, all kinds of things. Now, I want to say that on this matter, I read last week that in at least 3 areas, clinical commissioning groups are going to challenge any consultant-to-consultant referral that they feel is inappropriate as a way to cut costs below patient choice. GP practices will receive electronic copies of all non-emergency consultant-to-consultant referral letters relating to their patients, and then GPs will decide whether that referral should be made. I hope they're qualified to do that. And I apologize to any GPs that might be here today. Like I said, you're the good guys. Right. Supporting local initiatives, that means devolving power and responsibility for action to others. And go back to my comment previously about supporting local initiatives. That is actually patronizing. Because supporting means devolving, which transfers responsibility to a lower level, and delegating doesn't carry that connotation. You can actually do this through support groups. Service users are perfectly willing to tell their stories at training sessions or seminars like this one to help you get the funding you need, to help spread information, to help educate people about what it's like to have ADHD. They can also include working with support groups to get services established or securely functioning in your own area, or to create pathways for additional services such as psychological therapies. Because like I said before, we can say and do things you can't. Right. Summary. Pretty self-evident. We want participation, we want engagement, not just at the trust level, but with you at the practice level. And most of all, we want to lead so-called normal lives. There's things we want to do and to accomplish. And now, this is something I borrowed from Ornstein. I participate, we don't want this. I participate, you participate, he participates, we participate, you participate, they profit. This is what we want, teamwork.